Hey there, good evening and welcome. Guess what time it is? It is 5 o'clock on the Gulf Coast, which means 6 on the east, 4 in the mountains, and 3 in the west. And it is time for Fertility with Fink. My name is Dr. Randy Fink, and I am live from Pensacola, Florida this evening, where I am a fertility gynecologist at New Life Fertility, part of the First Fertility Network. And it is wonderful to be here with you all. Good evening, as we always are on Tuesday. Glad you could join me. Nice to see some old friends stepping in. Hello to Tracy. Oh, Patricia, nice to see you this evening. And Zenny, welcome as always. You know, it's kind of a rainy night. Looks like the storms are pulling in here on the Gulf Coast. So hopefully there's some sunshine and happiness where you are. But as always, it is a happy place for me to be. It is my favorite place to be all week long because it is our chance to talk about all those things that are important to us. And that is women's health and making families and getting babies and adding kids and doing all those things that make life meaningful. So I'm here to answer all your questions tonight. We've got some different feeds here. So interestingly enough, the New Life Fertility Instagram feed, which would normally be right over here, is not on tonight because Instagram has said that for whatever reason their account is ineligible, but thankfully mine is. So this is Randy Fink MD right here. We've got Facebook and YouTube and LinkedIn over here on this side. So please throw your questions this way and happy to answer them. I try to get to all your questions tonight. And if I am not able to do so, feel free to email them to me, and that is askfertilitywithfink@firstfertility.com, and we will get to those at the top of the show next week. How's everybody doing? How was your weekend? Hopefully your Monday was pretty uneventful. Mondays are tough, and it seems like as we age, they get tougher and tougher. Not that I'm aging, of course, but maturing. Maybe although that's certainly debatable, as well. But Mondays get harder, hopefully. But you know what? I really look forward to Tuesday and being with you here every week. Hello, OMG Kylie. Hello, Bryn. Angela, nice to see you here as always. Thank you for being here, Rosa. Marlena, thank you. We've got Kelsers, Mrs. Vance from the wonderful state of Kentucky. Thank you for being here this evening. Depita Hack, it looks like Depita, you are the first one to join over here, so you get a special shout out and a very special hello. I had a question earlier in the week, and that came from Vicky, and Vicky is asking, "Can you tell me something about egg freezing?" So yes, indeed, egg freezing becomes like a fertility insurance policy. Basically, what we do is that we do the first portion of IVF. We rev up your ovaries, get you to produce as many eggs as we can get, which we then retrieve from the ovaries and then store them. So rather than fertilizing the eggs like we would in an IVF cycle and creating embryos, those eggs are yours and can stay good really forever. And I tell folks, you don't necessarily have to use those eggs. It's just nice to have them. And the earlier in your life you are, the younger you are when we retrieve those eggs, the greater the probability that we will be able to do something with those eggs later on. So, for example, I might have a patient who is 30 years old, and she has decided that she wishes to cryopreserve or freeze her eggs. And so I say, okay, well, that's fabulous. We'll get those eggs from you. There's nothing to say that 3 years later, she's not in a situation with a relationship where she wants to procreate with that individual and can't just do it the normal way. But if there turns out to be a problem where she is not able to do it in the normal way, then at least she has eggs from 3 years earlier. The earlier you are, the younger you are when we get those eggs, the better off you will do. That same thing really, of course, holds true with IVF. No one early in their life thinks that IVF is going to be something they're going to have to do. Nobody really thinks that fertility problems are going to be something that plague them. But I bet you most people who go through the process certainly wish that at some point during their lives, they had thought to be able to save eggs. That technology has really come an awful long way compared to where it was, even 5 years ago, but certainly 10 years ago. In general OBGYN practice, it may not have really been something that we even had a discussion about. Nowadays, I feel very strongly that I want everyone to know what is your AMH. Your AMH is the measure of your ovarian reserve. And what often happens is that the ovaries will age at a rate or at a pace that's faster than the rest of the body. So as that AMH starts to go down, maybe it's an indicator that freezing eggs is a good thing, because it's going to stop time really on your ovaries. So freezing eggs, I think, is really one of the smartest things a woman can do. We talked a little bit about the AMH, and so let's just review what that is. AMH, or the anti-Mullerian hormone, is the measurement of your ovarian reserve. Now, we can't actually measure the number of eggs in the ovaries because those eggs they're microscopic. We can't see them by ultrasound. But every one of those little eggs, and you're born with all the eggs that you'll ever have, every one of those eggs is there the day of your birth, and they are surrounded by some cells. And these cells, these granulosa cells, manufacture a hormone that's called AMH, or the anti-Mullerian hormone. So the more of these, the more eggs you have, the more of these cells you have. And the more of these cells you have, the more of the AMH you make. So we can measure your AMH. We can see kind of where it falls on a graph relative to age. So if you start out, let's say in your 20s, the AMH level is up here. And by the time, we get to our 50s and menopause, the AMH is sort of down here. So we can see where you are relative to age and how quickly your ovaries may be aging. I really encourage everyone to know what their AMH level is, because that tells us about your ovarian reserve and has some impact upon what it's going to mean for you if you want to have babies later on in your life. So just my 2 cents worth. Hello to NYKYS, however you might say that, government user nombre. Hi there. Hey, to Kowser. Angela asks, is it true that Omnitrope can help with implantation for an embryo transfer? So Omnitrope, or growth hormone, and actually Angela's asking a couple of other things here. A new clinic only recommends 6 units, but I want to use more. How much Omnitrope do you recommend during stims for women over 40? I've had women who have used, I have friends who have used 25 units, which gave her 4 blasts. So let's talk about growth hormone. What's the deal with growth hormone as it pertains to fertility? The data on growth hormone is really very plus minus, Angela. There are some studies that show it makes a difference, and there are other studies that show that it really doesn't, that all it does is add a lot of cost, that it doesn't change the actual fertility outcomes. In my opinion, I have seen that Omnitrope really does make sense for some people. It does seem to improve the outcomes. Growth hormone is something that our body naturally makes, and our growth hormone levels diminish. They start to go down as we mature. So the question is can replacing that growth hormone make some difference as it pertains to what's going on at the level of the ovaries? Maybe it is that growth hormone is what helps our bodies to repair some of the age-damaged DNA that we have in our ovaries. And that's sort of one of the hypotheses there. So in the anti-aging world, in the weightlifting world specifically, people will use high amounts of growth hormone, like 25 units. Typically 6 units is the standard. The data that I have seen says that you really don't get escalating benefits by using more growth hormone than that. Now, there's also a difference with what you're talking about in terms of units. So, and I don't have a little syringe here. I would have shown you. If you have an insulin syringe that shows number of units, that's different than what we call international units, which is another standardized unit of measurement. I usually recommend 6 units of Omnitrope, which is typically going to be 2 vials to cover you for about a month's time. If you're using 25 units, or for that matter, if you're using 6 international units, you're using a very substantial amount of growth hormone, and it's going to be extremely costly. So 6 units is usually the recommendation. From the studies, there are some people who use 4 or 3. Sometimes we can use 3 earlier on in the cycle and then increase that to 6 during stim. But I have not seen data that says that using more than 6 units of Omnitrope improves the outcomes. Really, what it does for sure is increases the cost. So I know you had a friend who used 25 units. And again, I wonder if 25 units on an insulin syringe is equivalent to 6 international units. And I'm just not so sure about that. But 6 units on the insulin syringe is the one that I recommend. Is it true that growth hormone can also help with embryo transfer? There is some data to say that it helps with transfer, but to me, there are really 5 supplements that I recommend for embryo transfer. And that would be your prenatal vitamin, vitamin D, vitamin E, CoQ10, and L-arginine. If you have a history of endometriosis, I further recommend that you're on some vitamin C as well. So if you're doing those supplements, I think, to be honest with you, that's really very accurate, very adequate rather for embryo transfer without having to use growth hormone. They have studied growth hormone in the population of folks who have recurrent implantation failure to see if it improves the outcomes of embryo transfers in that scenario. And to be honest with you, there's another drug called tacrolimus or Prograf that has substantially better outcomes and really very, very strong evidence to say that that's the thing that you ought to be using. And that's 3 milligrams, or rather 3 milligrams a day, or 1 milligram 3 times a day, or 1.5 milligrams twice a day. That I would feel very, very strongly about. Less so for Omnitrope when it comes to embryo transfer, because really we know it adds a lot of cost with a very dubious benefit as it pertains to transfer. Now, for egg quality, for egg retrieval, yeah, I do like Omnitrope. Let's see. I saw another one here. Bryn asked, do you think Neupogen and Lovenox let's see. I think that's a follow-up to another question. Yeah. Bryn says, 15 weeks and 5 days today. Wow, that is fantastic. Any tips at this time? So by the time you're about 20 weeks pregnant, the top of your uterus is going to be about where your belly button is. And so at that point, you can kind of feel what we call the fundus right there at the top of really at your belly button. And thereafter, your OB is going to start taking a tape measure and measuring in centimeters from the tip of your pubic bone all the way up to the fundus of the uterus, or the top part of the uterus. That happens at about 20 weeks. And also at about 20 weeks, that's the point at which most people will start to feel the baby move. What does that movement feel like? Well, usually it feels like fluttering. So you may ask yourself, is that gas that I'm feeling, or is it, I'm really not sure. But pretty soon after that, that gas starts kicking you and standing on your bladder. So that happens at about 20 weeks. So close to 16 weeks, you're going to be starting to think about scheduling your anatomy ultrasound. The anatomy ultrasound. So we do, in the fertility world, we're doing a lot of ultrasounds in the first trimester because we're trying to follow the viability, to make sure that we see a heartbeat, to make sure that we see a pregnancy that's inside the uterus. But you really can't appreciate the anatomy very well. The spine, the four limbs, the hand, the bones in the hand, the shape of the brain, the shape of the abdomen and the heart, the four chambers of the heart. These are the things that we look at in an anatomy ultrasound, and usually that's typically done between 16 and 18 weeks. Some people wait until 20 weeks or so to do it, but because sometimes the anatomy may be limited, you may have to go back and get another ultrasound done. But that's what's happening about that time. So really very exciting stuff. Also in the 16-week kind of time frame is when we do an AFP test. AFP stands for alpha fetoprotein. And what that is that it is a marker for neural tube defects. It can also be used as a screening test for aneuploidy or abnormal chromosomes. Now, many people are doing what's called NIPT or non-invasive prenatal testing. So the NIPT is is certainly more accurate than the multi-marker testing that was called an AFP quad or an AFP penta. There are some other types of tests that can be done, usually hand in hand with when they measure the thickness of the baby's neck at around 12 weeks or so. But that's usually around 16 weeks is when we do the AFP, which is a test for things like spina bifida. It's a blood test that comes from mom. And Bryn further asks, let's see, where was it here? Do you think Neupogen and Lovenox did the trick, or do you think my egg was just a normal embryo? It was an untested embryo, and it was my fourth transfer that worked. That would be my guess. It almost always has to do with an embryo factor more than specifically an immunologic or an autoimmune type factor. Now, that isn't always the case. A lot of that really kind of depends on age. But if I had to guess, Bryn, the evidence on Lovenox is helpful. Lovenox is a blood thinner. If you don't know, Lovenox is helpful for people who have specific types of clotting disorders, and that's called a thrombophilia. That's something in their body that makes the body want to create clots in those tiny little blood vessels that supply the placenta and that supply the uterus and the pregnancy. So there is no evidence that using either Neupogen or Lovenox in the general population is helpful, but there is a small cohort of people for whom these things are helpful. The fact that it worked for you means great, and ours is not to wonder why. So if you went back in a couple of years and wanted to have another transfer, I would say, absolutely, I would do the same thing that you did when it worked. So if it worked the first time, hopefully it works the next time. So yeah, I would certainly repeat it. But is that what did it? Well, the data isn't very strong to say that Lovenox and Neupogen is helpful in the general population. Let's see. We had a question from Rosa. Rosa asks, is it true that a woman at age 43 should be induced by 39 weeks, even if there's no preeclampsia or diabetes in a first pregnancy? So different OBs think different things about that. We certainly don't want you to go much beyond your due date. We'd never let you go really beyond 41 years old, but there is no guidance that says specifically you have to be induced at 39 weeks, especially if your cervix is not favorable. So I would say if you're uncomfortable with that, a good negotiation there might be to say, well, I want to wait until my due date. Let me just wait until my due date. And I think that makes sense too. But remember that the placenta is an organ. And I've said this before. If you've heard me say it, please forgive me. But the placenta is an organ like any other that has a fixed lifespan. And certainly as we mature, and by age 43, well, that counts as mature, we start to have issues with the small blood vessels in our body. It's called microvascular disease, and it just happens really as a function of aging. So that same thing will start to affect the placenta. And at 43, we get much more worried about things like placentas, especially especially in pregnancies that are very highly invested in, that you have struggled very hard to get, like an IVF pregnancy. So that's the thinking about why be induced rather than wait for spontaneous labor. But if you are uncomfortable with 39 weeks, then say, well, how about I just wait till my due date? There's no specific guidance that says you must be delivered at 39 weeks. All right, what else we got going on here? Hello, Styles family. Nice to see you this evening. Ariel Eden joined. Hello, my friend. Good to see you also. S. Atkinson. Hello, Midgie. Mags Cambor is here. SM Fredericks, good evening. The Atkinson crew says, I just used my last embryo and it resulted in a chemical pregnancy. Should I test my next embryo? I had 3 this past round. 1 worked, 1 failed, and 1 chemical. So if you're asking, should you do PGT testing in another round of IVF? I would say, given the scenario that you're describing there, I'd say, yeah. I would, because, you say, well, 1 failed, 1 didn't implant. The most common reason an embryo doesn't implant is because of chromosomal problems with that pregnancy. A chemical pregnancy is almost always a genetic or a chromosomal issue. When you say 1 worked, well, not sure what happened there with that one. But if you do PGT testing, what you're doing is that you are really taking the genetics out of the equation, so that at least you don't have to worry as much about that anymore. Now, as well as I do, that PGT testing is not a perfect system. It's not perfect. They're testing from the portion of the embryo that becomes the placenta. They're not actually testing from the baby itself. And it's possible to have some discrepancy there where you have a normal placenta but an abnormal embryo. So that's possible, and you can still have a miscarriage, with a tested embryo. But given that we had at least 2 embryos that didn't work, likely because of chromosomal issues, you will, in all probability, decrease the number of unsuccessful transfers you have by testing your embryos. So to test embryos, we grow those embryos out to the blastocyst stage. So that's typically a day 5 embryo, sometimes day 6, occasionally even day 7. And they take a few cells from the outside portion of the embryo. That's the part that's going to become, that's called the trophectoderm, the part that becomes the placenta. And from that, we can get a sense of, are the chromosomes normal in that embryo? So it does add cost to your IVF. But there are some scenarios where that may be very worthwhile. That's called PGTA, pre-implantation genetic testing for aneuploidy. And that's the way we would tell, for instance, whether your embryo is male or female. And that's how we would know about aneuploidy versus euploidy, or normal chromosomes versus abnormal chromosomes. If you have a chromosomally normal embryo, that embryo gives you a 65% probability of pregnancy. If that embryo is abnormal or aneuploid, there is still a possibility that embryo could give you a normal pregnancy, but the likelihood of that is very low. It's probably around 5%. So, oh my goodness, look what you made me do. You made me yawn there right on live television. Wow, that was embarrassing. Sorry about that. Midgie says, love the specs. Oh, you mean these? Thank you very much. I try to change it up a little bit. I try to, I try to put on some different glasses depending on the outfit. When you wear scrubs most of the time, or you just kind of you don't have fancy, flashy clothes. The only way you can really dress things up is either by changing the frames on your glasses, or by wearing, multicolored socks. And so I like to do both those things: socks and glasses. That's what we're looking for. Let's see, Angelo, going back to the Omnitrope, 25 units in the insulin syringe. That is a boatload of Omnitrope, and Omnitrope is expensive. So I'm going to say, I think That's a little much for my book, if you ask me. Hi to Rose Cali Girl and JC Rodriguez. My journey with IVF. Thank you for sharing part of your journey here with us. La Mujer says, how long do you recommend taking prednisone and Lovenox after the confirmed pregnancy? No history of clotting issues, currently 14 weeks. Okay, so first of all, neither of those things is necessarily something that most practices do. Lovenox is, as we said, is a blood thinner, and the thinking there is that by using it, it may be increasing some of the blood flow that's going to the placenta, and without a history of clotting issues or recurrent pregnancy loss. I would say by 14 weeks, you're really fine to go ahead and stop your Lovenox. Usually that's something I would think about during the first trimester. Usually we also think about tapering off the prednisone by the time you're ending the first trimester. So now sounds like a good time to maybe think about doing both. If you're concerned there about the what the Lovenox is doing something for you, even though you have no history of that would suggest you need it, a baby aspirin may really do kind of the same thing. Now we know that baby aspirin and Lovenox have a different mechanism and can both be related to helping prevent different kinds of problems in the pregnancy. So I would say go ahead and stop the Lovenox and maybe think about being on a baby aspirin. Prednisone, you don't want to just stop outright. You do need to taper that off. And depending on how much you're on, everybody has kind of a little different sort of tapering mechanism. If you're taking 20 milligrams a day, which seems to be a very common dose, usually what I have you do is to go from 10 milligrams twice a day, if that's how you're doing it, to 10 milligrams once a day for a few days. And then from 10 milligrams, cut that in half to 5 milligrams for a few days. And then from 5 milligrams, maybe cut that in half to 2.5 for a couple of days, few days, and then you can stop. That's a reasonable. You can do a fairly rapid taper, but you don't want to just stop it outright. You'll start to feel pretty bad in all probability. Hello, Lala Official. Nice to see you here this evening. NYKYF. Forgive me for not saying that right, but is there anything specific you recommend for an FET for someone with endometriosis? And the answer to that is yes. So there's a couple of things. There's one thing that you can do specifically, even if your doctor doesn't tell you to, and that is vitamin C. So we talked about the 5 different supplements that are recommended, part of the evidence-based protocol for embryo transfer. So your prenatal vitamin, vitamin D, vitamin E, CoQ10, and L-arginine. Okay, so but if you have endometriosis, it's recommended that you are on at least 600, but minimum or recommended really 1,000 milligrams of vitamin C during that embryo transfer cycle. So that's number one. Number two is I do strongly recommend that you think about doing some suppression of the endometriosis before you put that embryo inside, before you transfer the embryo. So the recommendation is either that you have surgery to try to excise that endometriosis. And my personal feeling there is, why have surgery if you really don't have to have surgery? Especially if you know that you have endometriosis, you may have already had surgery. But the problem with surgery here is that when we operate on endometriosis, the endometriosis you see is actually the tip of the iceberg. There's always going to be more endometriosis than what meets the eye. So given that, I think medical suppression of endometriosis is probably the better idea, because that's going to take care of all of that endo, whether you can see it or not. So 2 ways to suppress endometriosis. Lupron is one way, and the other way is with a pill that's called Orilissa. There's actually a third pill. Myfembree can do it as well. I think the pills are a kinder and gentler way to do it. So that's kind of my recommendation. But 60 days of suppression 60 days makes a very substantial difference when it comes to embryo transfer with a history of endometriosis. So I sure do recommend that. Hello to Carly Steinkraus and Audrey Kristen. Carly asked, what protocol would you recommend for a first-time FET? I only have one BRCA negative euploid girl, so very scared to lose her. I hear you there. When you've got that one embryo, boy, it is a precious little commodity for sure. So let's talk about that. But before we do, let me just say thank you all for being here this evening. It's about half past the hour. We'll be here for another 30 minutes or so. I'm Dr. Randy Fink in Pensacola, Florida. This is Fertility with Fink. I am at New Life Fertility, and yes, we do see patients from all parts of the country right here. Pensacola is a wonderful place to come, enjoy the beach, enjoy the wonderful seafood, the great people, and leave with a lovely parting gift as well. How about a little pregnancy there? We're part of the First Fertility Network, which is a national company of the finest in fertility care nationwide. So check out their website, which is firstfertility.com, to find the office nearest you. But I'm here in Pensacola, and to answer your question, what is a good protocol for first-time FET? So there's really two different types of embryo transfer protocols that we use. One is called a medicated cycle. And the medicated cycle, or a programmed cycle, is where we are giving you all the hormones that your body needs. And in so doing, we are in fact suppressing your body's ability to make those hormones so that we can really control every variable as it pertains to your body. So all the question marks, all the plus minuses, and I wonder if my body is, all those things go away when we do a programmed cycle. We have a lot more control over the timing of that cycle and really on everything hormonally that's happening in you. Most practices in the United States typically will use programmed cycles, medicated cycles, for the majority of their embryo transfers. But there is another kind of cycle as well, and that's called a natural cycle or an ovulatory cycle. So what happens in an ovulatory cycle is that, well, rather than suppressing your own hormones and giving you all those hormones from the outside, what we really want to be able to do there is to let your body take a front seat in making those hormones on its own. So we usually let you build your own egg, like you do every other month that you have a period. Sometimes we do that by giving you a modification, and that is to give you some ovulation induction to make sure that you're going to produce at least one egg, and that you will do so in a nice, normal, and predictable fashion. We let that egg grow. What happens as that egg grows? Well, that's how you naturally make your estrogen. So you make your estrogen, that estrogen thickens up the lining of your uterus. That thickened lining becomes a nice, spongy, warm, juicy place for a pregnancy to implant. And then usually we'll give you a trigger shot. The trigger shot is to tell your ovary to release the egg. Once you release that egg, that place that was making your estrogen before and that was housing your egg becomes the place that makes your progesterone. So we usually give you a little extra progesterone, like some vaginal progesterone, but you don't have to do the progesterone in oil shot. Because when you're doing a medicated cycle, we have to give you all of that progesterone. You're not making it because we're, again, trying to control it. So there are different people who feel differently about these things. There is some data to say that natural cycles or modified natural cycles may have a slightly improved outcome, but the data is not sufficient to say that everybody should be doing it. Because again, in the United States, most of the cycles really are programmed cycles. We have decades worth of evidence to show exactly how to do that, and that it's safe, and that it is effective. But the natural cycle, you can say at the very least, is equivalent, that the two of them are equivalent. So one versus the other should be okay. which would be the best thing to do? I go back and forth. I really do like doing these medicated cycles, or rather, I really do like doing natural cycles when we can. But gosh, you've got one embryo there, and maybe it makes sense to kind of try to control every variable. There are some practices that really do a large portion of their cycles are ovulatory cycles or natural cycles. But again, most do the medicated cycles. So I think it's really kind of a good conversation between you and your doctor as to what they feel more comfortable with, what they are used to doing. Either one should be okay. Now, there may be a scenario, for instance, when you say, oh, no, you know what? One of these is actually going to be better than the other one. And what might that scenario be? Well, if you have a terrible phobia, for example, of needles, well, the progesterone and oil shot is not going to be your friend. Right? When I do medicated cycles here, we do typically do a progesterone shot that's every third day, and that goes along with some vaginal progesterone. So it's not something that we make you do every single day. But let's just say, whoa, I really can't do that PIO shot. Then I say, well, then you have every reason in the world to do a natural cycle. So that's kind of the way I would think about it. Look for a reason why one may be better than the other. Let's see. S. Atkinson says, oh yeah, it was hard. I was only 28 when I had my first retrieval, and now I'm 32. So I'm nervous with the outcome. Well, I will tell you that beyond 32, we start to see some decrease in egg quality, but the difference between 28 years old and 32 years old, Ms. Atkinson, should not be dramatic in terms of egg quality. Now, the difference between, let's say, 28 and 34 does become more dramatic. But 28 and 32 is pretty good. And I will tell you that the ongoing pregnancy rates, let's say in my clinic here, for a woman who is 28 with an untested blastocyst, it would be about 40% per untested blast. And that number would really be the same at 32. Now, when you do PGT testing on your embryo, that 40% number goes up by 25% to 65%. And given that we had a couple of embryos here that didn't perform as hoped, I think it's not an unreasonable thing to do for you to think about doing the PGT. What are your thoughts on taking a DHEA during stimulation? It's helped many a woman with egg quality. Well, yes, that comes from Angela. And you're absolutely right. DHEA is part of the evidence-based protocol for women with diminished ovarian reserve. And I would say that they're really probably on that list, and there's like 10 things. I always say, what can a handful of vitamins do to help us get pregnant? And it is a handful of vitamins. DHEA, 25 milligrams, 3 times a day, is part of the evidence-based protocol for diminished ovarian reserve. So yes, I do think so. And I think so irrespective of your DHEA level. Now, there is one caveat to that. If you have diminished ovarian reserve, but you have polycystic ovarian syndrome, I do not recommend DHEA in that specific scenario. But diminished ovarian reserve or really over the age of 40, DHEA 3 times a day has been shown to improve egg quality. And I think it is one of the top 2. I think I just started to say this. It's one of the top 2 things that I think are most important for egg quality from a supplement standpoint. The other one that is most important is the CoQ10. CoQ10 comes in 2 forms. One is called ubiquinol, and ubiquinol is the form that your body uses it. And if you're using ubiquinol, it's 400 milligrams that you need, typically in divided doses. So 200 milligrams twice a day of ubiquinol. The most common thing I find when I'm doing consultations here is that folks are on CoQ10, but they're not taking enough of it. And that's because the other form that's readily available and that's in things like the Nature Made CoQ10 is a form that's called ubiquinone. ubiquinone. Ubiquinone, or N-O-N-E, none, is the last four letters. So it's all or none. All, ubiquinol in an O-L, or ubiquinone for the one that your body has to convert. If you're using the ubiquinone form, you need a little bit more. You need 600 milligrams a day, or a minimum of 300 milligrams in a divided dose. So sometimes you'll see a 400 milligram ubiquinone. You just take two of them. But for whatever reason, most commonly, I see a lot of folks taking just 400 milligrams of ubiquinone, and that is not the evidence on what CoQ10 can do for you. So please check out your CoQ10, see what format you have. Ubiquinol is 400 milligrams a day, or 200 in divided doses, and ubiquinone is 600 milligrams, or 300 in divided doses. But to answer your question, Angela, yes, DHEA 25 milligrams 3 times a day has been well studied and has been shown to improve egg quality. So why is that? Well, DHEA is a precursor to testosterone, and testosterone is part of the steroid hormone cascade. Testosterone is broken down into one of two different things. It's broken down either into the active form of testosterone, which is called DHEA, or it's broken down into estrogen. And it's that estrogen that is improving the environment of the egg. And that's what's improving egg quality. So good question there. Thanks for that question. Very, very academic of you, Angela. Thank you. Audrey Kristen says, any tips for the PIO shots? Getting knots and sore after 5 weeks. Also, chances of miscarriage after seeing a heartbeat at 6 weeks and 5 days. Okay, so let's talk about that miscarriage thing. Once you look and you see the heartbeat, we know that 95% of those pregnancies will continue on without having a problem. And that is the best odds you can hope for. That's really exactly what we're looking for. So still, 5% of those pregnancies may miscarry. Is there anything that you could do to stop it if it was going to happen? The truth of the matter is there has not been shown to be any intervention that will prevent a miscarriage if it is destined to be. Because most miscarriages will happen because of an embryo issue, either a chromosomal issue with the embryo. Sometimes, we'll see a little collection of blood underneath the placenta, and that's known as a subchorionic hemorrhage or subchorionic bleed. Well, when I see that, I usually tell people, okay, I like to see you stop your Lovenox. If you're taking Lovenox, maybe think real carefully about the baby aspirin. Because if that expands, if that little clot expands, that can result in cutting off the blood supply to the uterus. And that means, pregnancy will end. So once you look and see the heartbeat, Audrey, boy, the odds are so much in your favor. It's a wonderful thing. Now that the odds of miscarriage goes down to less than about 1% by the time you reach 12 weeks. So we used to always tell people, well, maybe you want to, be judicious about who you tell you're pregnant until you are 12 weeks of gestation. Well, now, I feel pretty confident that if you look and you see the heartbeat, odds are definitely in your favor that you are going to continue that pregnancy. As far as the PIO goes, the first question I would say is, well, is there any room for you to be able to space it out a little bit so that you're not using PIO every day? If you've done a medicated cycle, you have to use PIO. There are some people who say, I don't like that shot, I'm not going to use it. And I would say, oh gosh, please don't go there, because vaginal progesterone alone is not sufficient to maintain a pregnancy if you have done a medicated cycle for your frozen embryo transfer. So you do need to have some of it. But like I said, in our practice, we're dosing that such that it's every 3 days. And that is enough to maintain a level in really 99% of people. But put some ice on the spot where you're going to do it. Ice it first, and then once you've done the shot, use heat afterwards. That will help with those knots. Make sure that when you're injecting the progesterone, that the entire contents of the syringe is going into the muscle. Because one of the reasons you start to get these real sore knots and these long-term bruises and things in your butt from where you're giving yourself the shot is because some of that progesterone is coming out of the needle as the syringe is being withdrawn. So if you get the progesterone compound into the fatty tissue there, that will create an immune response, which is what gives you oftentimes what gives you these big knots. Now, just putting a needle through the fatty tissue can sometimes give you what's called traumatic fat necrosis. It can cause some scarring in the fat cells there as well. But to the extent that you're able, make sure that the needle stays in until you are done with it and that you're not leaking progesterone out as you withdraw it. Hot compress after the injection also seems to help with those issues of the knots and of the big sore spots and of the bruises. There is a device, and the name of it I am blanking on. I can't think of it at the moment. That is like a little belt that you wear, and if you put it on correctly with the middle of the belt, like right on your belly button at the middle of your waist, it will show you the exact spot. There is a place on it where you are to give yourself the shot. So you make sure you're giving it in the proper place. And it's got a little space to put a little cold pack on it so that it cools that down. So in lieu of ice, it's like one of those little frozen things that you can keep in the freezer. And that's a nice way to do that as well. So good luck with that, Audrey. And congratulations on the pregnancy. I can't wait to see your baby pictures. What happens if you don't taper off prednisone? Is it dangerous? Yes, it can be dangerous. It can cause what's known as an adrenal crisis. But even still, even if you don't do something that puts you in the hospital, it can just make you feel like crap. And that's the medical term for it. You feel like crap. Headachy, blood sugar all over the place. Blood pressure can be quite volatile. You can retain water, lose water, and just but really it can have a very detrimental effect on your adrenal glands. So when we give you these medications called adrenal corticosteroids, and that's what prednisone is, we want you to taper off of them, especially if you've been on them for more than just a few days. Now, there are times when, let's say you have some very severe upper respiratory infection and you go to the primary care and they give you some steroids. Well, sometimes it's just a short course of steroids, maybe just over a few days, where you don't actually have to taper. But really, if it's more than a few days, tapering really does make sense. So trust me on that one for sure. Is endometriosis going to be suppressed during breastfeeding too? And the answer is yes. So as long as you're not menstruating, then endometriosis will be suppressed by the hormonal state that's suppressing your hypothalamic pituitary axis. Breastfeeding causes an increase in your prolactin hormone, and that prolactin suppresses your ovulation, and that will keep you from releasing an egg, and that does suppress the endometriosis. Now, eventually, after breastfeeding, usually by about 6 months, sometimes sooner, women will start to spontaneously have periods again. But as long as you are breastfeeding full time, at least in that first 6 months, you are probably protected. Are you completely protected? No, you're not. So can you get pregnant while you're breastfeeding? Oh, hell yeah, you can. Do you want to get pregnant while you're breastfeeding? Oh, hell no, you don't. You don't want to be pregnant when you have a 2-month-old at home. Is it possible? Oh, yeah, it's possible. So I always would talk to folks when they come in for their postpartum visits about what are we going to do now for your birth control. And so many people would tell me, oh no, gosh, you don't know what we had to go through in order to get pregnant. You know how many cycles of IVF we had to do. Gosh, it was quite the ordeal. And I say, yeah, but the plumbing gets plumbed. Things do change. And so, yeah, it's possible that you can get pregnant even when you had a real hard time getting pregnant before. So we always talk about birth control at a postpartum visit, and that's the reason that they invented the so-called mini pill or the progestin only pill, because it was specifically originally for breastfeeding moms. Nowadays, people use the mini pill for a lot of different indications, but yeah, endometriosis will be suppressed there. Hi, Tara. Nice to see you this evening. I saw some great pictures of you on Instagram. You're looking awesome. Sydney, hi. Nice to see you here. Karen, the famous Karen Amos of embryology fame, at least was here. Don't know if you're still here, but if you are, thank you for being here. Saw some great pictures of you, and congratulations to you on all your accomplishments in the embryology field. What protocols or treatments help to lower autoimmune inflammation while trying to conceive? Well, so let's say this. It depends on what the source of that inflammation is. One of the best treatments for that inflammation is actually low-dose naltrexone. I used to use a lot of low-dose naltrexone, and I'm starting to use it a little more here in Pensacola now. Low-dose naltrexone has a very strong effect at minimizing autoimmune inflammation by increasing the amount of endorphin that your body makes. Your endorphins, like the runner's high, endorphins that happen after certain types of sexual activity, certain other things. After you have a baby, that's a big endorphin rush. Increasing your endorphins is probably a good thing. It feels pretty good most of the time, but it also has a very strong effect on protecting protecting against treating inflammation and autoimmune functions. So low-dose naltrexone is a really good thing. Sometimes Plaquenil can be helpful. A baby aspirin can be helpful, and certainly antioxidants in the form of your vitamins are helpful, and that's why there are specific evidence-based protocols on what type of supplements we would recommend that you use. Hi to Marin. Is that the Marin? Why, if that's Marin, famous Marin from New Life Fertility, thank you for being here this evening, and I know what you're laughing at. Hi to Erica, Alyssa, and Liz, Carmen. Thank you. Mrs. Villarreal, haven't seen you for a couple of weeks. Nice to see you. T. Andres asks, why isn't testing the vaginal microbiome part of infertility testing? And the answer is because there's really not a lot of evidence that shows that it makes a difference. There are companies out there that now advertise, that you can via the internet purchase a swab that you can test and see kind of what your lactobacilli, what your normal vaginal flora is made of, what the makeup of that is, and how it can be altered, how abnormally it is altered sometimes, and how you can alter it for certain things. And that's all, certainly very interesting. But there was a company, or there is a company, that was offering a test called the Emma and the Alice that went along with what was known as the ERA. The ERA is the endometrial receptivity assay, and it has really, by and large, been debunked as something that is meaningful in terms of folks and why they may have implantation failure. But it's a very expensive DNA probe that looked at what type of lactobacilli you have, looking at the sort of the uterine or the vaginal microbiome, and it sounded like such a great really unique thing. But it was incredibly consumer driven. It was really advertised more to the public to say, hey, you should do this. You should test it. You should know what that bacteria is. Don't you know that you have bacteria in your vagina, and you should know what that bacteria is doing? It's having a party without you. You should know what's going on there. But the truth is that the data really didn't support that. That, yeah, if you have bacterial vaginosis, that's something that, we prefer you not to have. Many people with BV are symptomatic from it. It's the most common vaginal problem that women have, and it's associated with a discharge, and that discharge often has an odor to it. That odor is typically worse after sexual intercourse. And if that's the case, it is typically not something that you can treat naturally. Usually it requires a little antibiotic sort of treatment. There's some people who have said they like to try to treat it with boric acid. I don't recommend that because boric acid is roach poison, and I don't advocate roach poison in the vagina unless there is one certain type of yeast that is resistant to things like fluconazole, diflucan, and that's called Candida glabrata. And glabrata, really the only thing you can treat that treats it is boric acid. But to treat BV with boric acid, I don't recommend. Again, it's poison. If you have a discharge that has an odor, then I think that is worth being seen about, and it is worth testing. But specifically as it pertains to pregnancy, knowing what that bacteria is in the microbiome really just hasn't panned out to be something that's all that useful. It doesn't change the outcomes. Good question, though. Hi to Shada. Oh, Bamagal is here. That is my mom in Mobile. So they have the hardest doggone time being able to log into this thing and staying on. I'm glad you're here. Thank you for being here as we're working towards the close of the show. Sorry, I didn't tell you before. Mrs. Villarreal says my IGF test my IGF-1 test was 201, and I want to start on Omnitrope. Is that a bad idea? I'm going into my third retrieval. So the IGF-1 test, that's insulin-like growth factor, that's considered to be a marker of your growth hormone levels. And if we were talking about using growth hormone for anti-aging purposes, then I would say, well, you're kind of right on the borderline for where we would want that to be. I usually like to see that above a 200 if you're going to be considered normal. You're at 201. So from an anti-aging perspective, I'd say, yeah, you could probably use some growth hormone. But I don't bother testing it because that number or your growth hormone level doesn't so much correlate to the potential activity of Omnitrope or growth hormone in terms of IVF. So I would say yes, Mrs. V. I think irrespective of that number, or even despite that number, you are a good candidate there for Omnitrope. Lamu Hair says, how long do you recommend staying on estrogen and progesterone after a successful transfer? Would you treat or suppress with an H score of 1.6 on Receptiva, or just transfer because it's so low? So first of all, when you do your progesterone, you want to stay on it until the body takes over, which is usually at about 9 weeks. So typically we stay on the estrogen progesterone until about 10 weeks of pregnancy when you're doing a medicated cycle. As far as a Receptiva is a non-invasive test that looks for a marker associated with endometriosis, and a 1.6 would be considered a negative test, if I'm not mistaken. I think, I can't remember off the top of my head, but I think a 2.5, above a 2.5 is considered positive. But if I'm wrong on that, if the test says negative, then no, I do not think you need to treat. If I'm wrong and that is a 1.5 and you're at a 1.6, then yes, I would treat, but I think it's a little higher than that. So I would treat based on the qualitative result of that Receptiva. If it says positive, then yeah, I would treat. We're going to run out of time here. And gosh, I see Shada's got some questions here, and Simply Simpson. And gosh, man, I'm going to run out of time. So if you would, please send me those questions at askfertilitywithfink at firstfertility.com. Ask Fertility with Fink at firstfertility.com, and I will answer them first thing next show, which will be next Tuesday. As always, I am so honored that you would spend a little of your time with me, and I'm very, very thankful that you allow me to spend a little of my time with you. Please remember that this fertility business is not the book of your life. It is just a chapter. And what are we here to do? We are here to rewrite the thing, and we're here to do it together. Every step forward with love, every step forward with kindness, and every step forward knowing that tomorrow, my friends, is a new day full of all new adventures and all new hope. So until next week, I'm Dr. Randy Fink in Pensacola. Thanks for being here. Good night. See ya.